thumbs up when you feel it. All right, that was fast this time. Welcome back, everybody. No, it's all good. Steve Oswald here, physical therapist with Idaho Spine and Sports PT. Thanks for tuning in. We'll let some people roll in as we get started, but you should be able to play back most of this as we go live. We've resolved a lot of our technical difficulties from last time, so hopefully we don't have any issues with that this time. Today we're going to be talking about what we call anterior knee pain, otherwise known as patellofemoral syndrome. I know that's a big, complicated word, but it's just referring to the anatomy in the front of the knee. So anything anterior is just the front part of the body. So front of the knee pain today. It's a very common disorder, very common area to experience symptoms within the knee. In fact, it's the most common area to refer symptoms in the knee, and it's the most prevalent running-related injury that's out there. So for all you runners out there, there's a reason it's called runner's knee. So it does affect a large portion of the population annually. Something around 2.5 million people get this every year. And one of the main reasons I wanted to do this video early in our series is because it is so prevalent, and it also has a very high level of reoccurrence. About 70 to 90% of people will have a recurrent episode of this type of knee pain, and it is preventable. You just need to do the right things to try to accommodate those stresses in the knee and make sure that you're taking care of the things that are causing your symptoms. About 3 out of 4 people, when they get this over the course of the next 5 years, typically reduce their level of activity from where they were before they started having pain, and that's a problem. I mean, we want to be able to stay active, stay running, jogging, biking, just simply going up and down the stairs or not having your knee hurt when you sit and watch a movie. I mean, that affects your life, and so we want to address any of these components that are contributing to that front of the knee pain, and there's frankly a lot of them. Okay, when we talk about the front of the knee, we're really referring to that kneecap area. So Jalen, go ahead and extend your knee all the way out for me. And go ahead and relax down.
So real quick, if you can just check in with everybody if they can hear you okay.
Yes, can you guys all hear me okay? Is the audio good? That was our biggest concern with switching this platform. Are we good? Let me know if there's any complaints. We're awesome so far. Okay. So the front of the knee, that area that we refer to as the patellofemoral joint, just surrounding the kneecap and behind the kneecap. Most oftentimes with patellofemoral pain, we feel it just radiating around the knee itself or behind the kneecap. It's not uncommon to have pain that's kind of on the side of that area of the kneecap or just below in that tendon area. Both of those phenomenon we do group into this grouping of patellofemoral syndrome, but they have a little bit different mechanism for why they occur, and they have a little bit different treatment than what we're talking about today. We can make a video on that if we have interest, but these two areas specifically we address a little different than what we're talking about today. Because the knee is kind of this joint that's stuck between the ankle and the hip, it oftentimes gets told what to do and how to move from those two areas. So a lot of our initial interventions for addressing the knee are not only knee specific. They're going to be things to address any sort of positional issue or motion issue at the ankle and foot, but then also contributing factors, specifically how well the hip can control your leg, specifically with strength, and that will affect the knee itself. So there are many different interventions that we will do to those areas that can help. The first thing that I just want to talk about before we do exercise to address this, because exercise is frankly the gold standard of all medical treatments to help with front of the knee pain, is talk about the foot. The key thing that we know from clinical practice guidelines that were published last year is that one of 3 things that seems to be very helpful for this condition is getting a foot insert. So just a arch support that supports your arch. It doesn't have to be customized. It could just be prefabricated, something just off the shelf. Dr. Scholl's, don't want to name names, but any of those ones that you just get from the store or a drugstore, pop it in your shoe, give yourself some support. What we do find is that when the foot or the arch collapse, that puts the whole rest of the leg in a position that torques and puts extra stress into the front of the knee. Go ahead and stand up for me, and we're going to kind of show what that position looks like. So when you have your foot collapse, so that arch kind of tilts in, like Jalen is showing there, we call it pronation. That's going to tilt the shin out a little bit, but that's going to kind of add a torquing effect into the knee when we go into that position. So when we have flat feet or that arch collapses when we're running, walking, standing, it's just putting extra stress in the knee. So simply popping something in there to give you some support takes the stress off. The thing is that typically only works short term. The body's really good at adapting to kind of new positions. And so while that may be something that's contributing to front of the knee pain, what the research shows, what we see clinically too, is that only helps for about 4 to 6 weeks. And the recommendations say, do this insert, put this insert in, and do exercise. So you don't get to just escape the exercise portion with this. But the insert is helpful, especially if we're having the foot collapse. The second thing that we look at, especially from the hip, and we're going to talk about this briefly now, but reintroduce it back in when we go over squatting, is the hips component of this, where if your leg is collapsing inward, when you walk, run, when you walk, run, squat, go up and down stairs, if we're experiencing that knee collapsing in position, which is not a phenomenon that the knee really controls well, it's really more in the hip. That's the hip muscles not controlling well, having the thigh bone drift across. If they're not controlling that, that affects the knee. And that's where some of our exercise interventions are going to target. So that's why we're going to come back to that in a moment. The other major thing that comes up in our guidelines for helping short term, besides exercise, are doing taping to the front of the knee. So there's a specific technique called McMillan taping. It's literally where you have a special kind of tape. It looks kind of like athletic tape, but it's a little more sticky and rigid. And we literally move that kneecap slightly and tape it down and attempt to reposition it. But really more than anything besides repositioning, it just helps redistribute some of the pressures from that kneecap as it slides in that joint. So I'll show you kind of what that will look like. Jalen, go ahead and sit down for me again. If we were to tape it, we literally kind of put the knee in a semi-flexed or a straight position, and we push the kneecap over slightly, and then we'll tape it down and secure it so it's kind of moved over a little bit. And just maintaining that position just seems to reduce some of those symptoms. But as you can imagine, taping it every day or every other day is a lot of work. It starts getting expensive. And again, this is one of these things that both clinically and with the evidence, it only helps for maybe 4 weeks. The use of taping is helpful, but what we find is that using braces and straps, compression sleeves, all the other stuff that you can get for your knee to try to offload it or reduce symptoms for anterior knee pain, none of that stuff seems to help. Other knee conditions, it may, but with this, it's actually, more often than not, it's either going to do nothing for you, or if we're having a compressive issue with that kneecap where it's pushing too much in the joint, it's actually going to make your symptoms worse. Using those braces where it has the cutout within it, or just pure compression, it doesn't seem to be helpful for this. So far, shoe insert for the arch, taping can be helpful. That's something we can discuss more, demo in a quick video later if you guys are interested. That's definitely more of a skill technique, and so if you're experiencing this, reach out to us and we can kind of show you and run through it with you and make sure it's appropriate. But lastly, it's the third thing that we see consistently in the research and clinically is exercise with this. And not just any kind of exercise, but specifically exercise to strengthen the quadricep muscle, so that muscle that sits right on top of the thigh and goes into the knee, and the hip muscles, specifically what we term the posterior lateral, or just the glutes, the area on the side of the hip, biggest ones of the body, right? Strengthening those two areas in combination is better than strengthening just around the knee, and it's essential for strengthening both of those areas when we use the taping or the foot insert. Nothing in isolation seems to work well. Only strengthening the knee, it's not as effective as other things. Only taping, not as effective as all these things together. And that's why we truly try to take a holistic approach to this. We got to address all these little factors, because oftentimes it's all these little factors together that are leading to those symptoms, okay? So have we had any questions so far? Nothing coming up?
Nope, not yet.
Cool. I must be explaining things really well then. Okay.
You are.
Oh, right. I have 3 exercises that I've prepared today to show you that will address this. 2 of them will work in isolation, one for the knee itself, for that quadricep muscle, one for the hip in isolation, and then one that combines the two in a very functional way. It's one of my favorite exercises, one of Jalen's favorite exercises, right? And so we'll reveal that in a moment. When I do want to say before doing this too that if you're experiencing this type of knee pain, it's important that we're screening this and knowing that this is the type of pain that's going to respond well to this, and that your symptoms are not too chronic, where they've lasted longer than 3 months, or that they're not too high level to tolerate these exercises. Even the simple ones I'm going to show you today, there's a possibility it may be aggravating, in the sense that, especially if we're having really high level pain, 7 out of 10 pain or plus in the knee, it's actually recommended not to start your knee strengthening exercises immediately and only work into the hip first. And then once things have resolved and calmed down to an extent, and you can tolerate doing that exercise into the knee, that's when we want to initiate more of those knee-specific strengthening activities. So don't think that all of these things are appropriate for you or for loved ones immediately. It is something that you do want to know is appropriate first. Okay. Our first exercise is going to get into the knee first, though. So this exercise works almost purely in isolation, which is a rare thing that we experience in the body, isolated motions for exercises. The exercise is what we call a long arc quad. It's long arc because it's a big amount of motion through the joint, and it's quad because it's going to work the quad. Okay. To start this exercise off in the most basic sense, it's literally just doing a kick in a sitting position. But when the knee is really irritated or a lot of pain, or maybe have a lot of weakness because we've been experiencing this for a while, we only want to go partial range with this initially, specifically the range of where the knee is bent to only halfway extended straight forward, right? Like he's showing you right now. He's not going all the way straight. It seems that when the foot itself is not affixed to the ground, like when we're walking or squatting or going up and down stairs, when it's kind of moving by itself like this, that the forces that go through the front of the knee seem to be higher. It's near the end range of motion. So when this is irritated, we try to just respect that a bit and only go through those partial ranges where we're not all the way straight, just 90 degrees to roughly 45 to 30 degrees at the end there. You notice that we don't have any weights on there, and sometimes that's okay to start with. If you have access to ankle weights at home, strapping one onto your ankle is appropriate. You can also tie resistance bands on to the chair itself, so where it's anchored to the bottom and then anchored to your foot, so you have a growing amount of resistance as you're kicking, right? We're not demonstrating that today, but it's just in theory something you can do. To further progress this exercise, and as long as it's not too aggravating to go through these motions, again, a very small amount of discomfort with this is sometimes appropriate, but again, that would be something you'd want to discuss with your healthcare provider or PT. If it's not too bad, we want to extend all the way to full range. Train through full range is just more efficient than partial range. So we want to kick all the way out straight, getting that knee, just strong contraction there at end range. You can see how it kind of tightens up. We're almost hyperextending. That's the perfect position that we want to be in, where we get a nice strong contraction. And you'll really feel that working in that muscle hard at that end range where you're squeezing, okay? Now, it's okay to really extend all the way into end range with this. Even if you have a few degrees of hyperextension to strengthen all the way in that's fine. That's your range. You need to be able to strengthen all the way through that available range. But what we want to avoid too, oftentimes when we're having a lot of pain, is if we're kicking, you're trying to avoid kind of stressing the knee too much. And you'll notice that, and he's demoing this right now, that sometimes you'll kind of kick the leg out where it's turned out somewhat sideways. All it's doing is kind of just changing that angle of the knee slightly sideways, so it's not quite lined up against gravity. It makes it easier, right? So it's not torquing the knee as much. So you do need to make sure that that toe is pointed straight up and down and not turned out when you're doing this. It's probably one of the more common movement compensations that we see with this one. Otherwise, it's quite simple, right? Quite simple exercise. So starting off partial range, extending into full range. Watch the toe so it's not turning out. I want to show you one more progression though, because again, if you don't have access to ankle weights or resistance bands, if you don't have these things at home, maybe ideally, hopefully, you have something else like a giant exercise ball. Stability balls, yoga balls, Swiss balls, there's a lot of names for it. It's all the same thing. But you can actually use that tool to provide some resistance with this exercise. Granted, you have a chair and the ball and an open wall. Okay, so we're going to move gears here. We're going to shift the chair over to this open space. Jalen will sit in the chair there. We've got our ball, and we're going to pin that against the wall real low, okay? And Jalen's just going to position himself where he's got his toe tucked underneath it, right? And he's going to do the same type of exercise, right? What you can't see truly is how much he's working when we do this, because he's attempting to straighten his leg out, but the ball is resisting him. But the ball does have some give to it, okay? So when he kicks, he's just holding that firmly, pushing hard, trying to extend and kick the knee straight, and then relaxing. So those are his repetitions. He's kicking, relaxing, okay? You can play through different positions with this too. It's good to strengthen through a lot of different ranges. Obviously, this is not something where you'd be able to do it well if your knee was all the way straight. You just don't have the capability with where this is positioned. You could stand and attempt to kick into it that way too. It's not quite as comfortable as this, but you can try it. But it seems to be in that bent leg position where it's 45 degrees or less. You can kick into this thing pretty tough and really get a good workout. Even if you're pretty strong, you can try this and it's working you pretty good. You want to hold those contractions for roughly 5-6 seconds, which is a pretty long time to hold that. And like most of our strengthening exercises, right? You know, kind of minimum 8 times, maybe up to 15 rounds. So kind of play in that range, see what you can tolerate. You know, see how it is the next day. It's not too flared up, and especially not swollen. We should expect swelling with this type of condition. But that's your progression for the long arc quad. So partial range, full range, exercise ball against the wall. Hopefully you have it, okay? We haven't had any questions yet from those. We're good? Sweet, okay. So that's it for knee, specifically. We're gonna jump over onto the table to do our hip exercise that isolates kind of that posterior lateral, that glute area that's really important for controlling the knee position side to side. So we're gonna switch legs. Jalen was demonstrating for a right knee issue. It's gonna be a lefty now. So if you joined us on Monday, we had a sideline rotation exercise for the shoulder. This is the rotator cuff strengthening exercise for the hip. Your hip does have effectively a rotator cuff too, right? It's got 6 small, deep external rotator muscles that act to help to stabilize and control it, but it also has larger, bigger muscles, to control that hip position and produce a lot of force. Because again, the hips, they're big, they're strong, and they need to be to help propel our body weight with everything that we do. So this specific exercise is called the clamshell exercise because it looks like with what we're doing with our legs, clamshell opening up and down. And from my understanding too, I think this exercise was demoed with the low back pain workshop. Lost for words now. Workshop that was done last week. So if you have low back related concerns, definitely reference that one. Go back and look at that from Friday. But we're going to review it again too, because specifically this is one that, again, it helps with a lot of areas of the body. This is going to help with the knee specifically. This exercise, again, you are completely sidelined. Your shoulders should be stacked, straight up and down. Same thing with the hips. We're not letting our body rotate too far backwards. So so again, sometimes it just almost feels more comfortable to kind of tilt back a little bit, but you want to be straight up and down. Your heels are going to be in line with your hips and your shoulders, so you got a straight line through there. Knees are bent roughly kind of 60 to 90 degrees, so he's in a really good position here. Okay? All we're going to do is keeping heels together, bring your knees apart, so you're lifting through your hip, and then controlling back down, right? We don't want it to block. We want to resist gravity, controlling up and down. Now, a few things do go wrong with this, especially as you're first learning this. The key thing that almost always happens consistently is as you're lifting, you start rotating your body with your hip to try to get more leverage, so you're avoiding using your hip. Because if he were to keep his hip position exactly right there and come back to normal, you see his knee only came up that far, so we're not using the hip more. But if he keeps his body steady, he can go up higher, right? So we're kind of avoiding that hip if we rotate. And the second thing is, as you kind of start going through the motions, and if you maybe aren't just not thinking about it, I guess, as you lift, you may separate those heels a little bit, okay? Like lifting the leg up. That is going to make it harder, don't get me wrong. But as in the early phases of this, we want to keep the heels locked in together, so really going through that supported motion. And then as a progression, add more resistance or add more vigor to it, and not necessarily instability like you would get with that position. Because the key here is going to be strength. We really want to push it hard and not just make it kind of arbitrarily more unstable with bringing the heels apart like that. Okay, we want to keep them touching. Okay, so those are really the two kind of big things that we want to avoid with this. Is rotating the body either before you start or while you're doing the exercise itself. Keep everything straight. Heels together as you move through that motion, going through as much of that motion as you can. Oftentimes, some people find success with doing this exercise on the floor, which I know doesn't sound comfortable, but if you can get up and down from the floor well, if you back your body all the way up to a wall, your whole back, hips, and feet, well, heels should be touching the wall, and that's going to block you completely from cheating, right? And you'll actually, if you do it that way once and come back on the table and do it again, you'll realize how much you were probably cheating the last time you did it. So again, if you feel comfortable with that, that's one way that you can get in and just make sure that you're not doing it wrong, okay? This exercise can be progressed in a couple ways. Again, this is the standard way of doing it, but like I talked about, we really want strength in this position. So adding some sort of external resistance is not the only way to do that, but it is by far the best way to do that. So again, if you have ankle weights, strap it onto the knee, go through that motion with a knee, something heavy on there. If you have other weighted objects around home with other fitness equipment that might be random, you can find a way to makeshift strap it on, just make sure it's safe. You can use resistance bands, which I'm going to show you next. If we have our band, we can loop it, just tie it, make sure it's secure. And again, we want it just above the knees, so it's not right at the knee joint line and away from the kneecaps, it's above that. We're set back up in position. I gave him a heavy one. Blue's usually pretty heavy. Universal system for intensity is yellow, red, green, blue. Each next color is usually double the resistance of the last. That's a little trick if you didn't know that. So blue is a pretty heavy band. We want to go through the same motions, same things, going through as full range of motion as you can. The great thing about this too is it becomes harder the further into that motion you get, and that's a good thing, right? We want to be really getting strong at those end ranges to keep the knee from pulling in this way when we do, again, stairs, squatting, walking, running, all those things, okay? So this is progression number one. We can take this same exercise and concept from the table and do it standing too, which is both a progression, but also translates better into just typically the functional things that end up creating your pain. Again, like I keep bringing up, doing stairs, because again, if you've got anterior knee pain, going up and down stairs, it hurts. Squatting hurts, and typically running hurts or lunging hurts. All those things, again, are where your foot is in a fixed position, so we want to eventually take this type of exercise and put your foot into a fixed position where we're standing, okay? So that's where we're going next. So we're going to hop up. We're going to keep the band on for now because we're just going to reposition it. Now, this next exercise, if you've seen it before, you may have seen it similar to the way we're going to do it now, because you can have the band in a different place than where we just put it. We just moved the band all the way down to the forefoot, so like just behind the toes, but below the ankle. There's a real good study that came out early of last year that looked at different band placements for this exercise that we're doing, and it found that this position compared to at the ankles or at the knees was most efficient at working the hips and best at not activating certain parts in the front and side of the hip that we kind of want to detrain with this phenomenon. So this seems to be the best position for it, as long as you're not kind of tumbling over yourself, okay? But it can be done with others. It's not bad if you do it with the band in other positions. Just know this seems to be the best way, okay? What we're going to do is take side steps with the band in this position, okay? So Jalen's going to face me. He's going to take kind of a shoulder width stance, right? Slight bend in the knees, okay? He's staying tall, and he's going to lead with his leg, taking a step, and then control him back. Notice what he's doing. He's doing a great job keeping his feet facing forward. He's not turning his foot out to lead. He's keeping it forward, right? He's keeping his knees wide. He's not letting his leg collapse in like that as he's stepping. He's leading with the knee as he's going. Perfect. by far the most common compensation with this exercise. As you're taking your step with it, you tend to lean away. You'll kind of reach out and go like this. And again, it's kind of same concept of some of the other things we did earlier, where you're just kind of cheating the hip. You're effectively not moving the hip. You're just keeping it in the same spot. It's still working, but when you lean, you're not kicking it out to the side. You're not working it as hard. So stay tall, lead with the leg out, okay? Control it back in, stay tall the whole time, slight bend in the knees. I know there's a lot of instructions, but each one of those things ensures that you're kind of stressing the right areas as you're doing this exercise. Again, this is a more advanced version of that clam exercise, so it may not be ready initially, right? But this is a great way of working into those hips, especially the posterior lateral hips. You'll get a good burn with this, especially if your band is relatively heavy. You don't have to do it with a band, but having even slight resistance with a light band with this exercise makes a big difference for working those hips compared to no resistance at all. So that is our hip sequence, right? Starting with clams. We've got our band around the knees doing clams banded, and then a standing side shuffle with the band around specifically the forefoot, so it's below the ankle, okay? So last but not least, we've got our kind of combined exercise, right? So it's everybody's favorite. Nobody likes it when we have knee pain, but it is a really, really good knee exercise, and frankly is knee friendly if you do it well. And it's the squat, okay? Again, time and time again in the research, it shows that doing squats specifically for anterior knee pain is helpful. It's not harmful. There was research from back in the 60s that led to education within physicians and PTs to say, hey, if you have knee, patellofemoral syndrome, no squats, no lunges, avoid those things. They're bad. We know that's not true. We've known that's not true for 10, 15 years now. It's old news. It's fake news. We're doing squats now. Okay, they're safe. You just need to do them in the appropriate manner and what you can tolerate. Okay, so same concepts with the other exercises that we've done so far. We want to progressively move into those ranges and progressively increase the resistance or challenge based off how well you do. So when we're performing our squat specifically for front of the knee pain, we want to assume a shoulder width to slightly shoulder width stance. Your feet are basically straightforward. They can be turned out slightly, 5-10 degrees, right? Kind of whatever's most comfortable for you. That's kind of based off of your specific hip anatomy. So everybody's a little different with that, so it's fine to turn them out a little bit, okay? The key thing that we need to do to initiate this well, that most folks when they start doing squats get backwards, and that's okay if you haven't done it as an exercise before, is to make sure that you push your hips backwards initially. So that first motion is back, okay? And what it's not is knees bend here. Not here, yes, here, okay? What that's gonna do, that's gonna initiate more weight back into your hips to engage the gluteal muscles to help with that squat position. And it's actually gonna reduce the stresses put into the knee when you lead with that hip hinge backwards first, okay? As you descend into it, again, it's good to start if you haven't done this before, just go halfway down. We call them quarter squats, right? We're just going down about 45 degrees, stop, and come back up, okay? Now you can see from the side, Jalen did an excellent job kind of pushing the hips backwards, right? Leading with the hips. If we come from the front side, the front mechanics are equally as important because again, one of the key things that we want to watch for is that knee collapse position where they're dipping in like this, right? Because that is the key movement pattern that overstresses this area. So as we squat, we want to think about knees apart, kind of pulling it apart. Imagine like a small saddle or something around you that you have to kind of squat around, right? So always keeping those knees apart and not dipping in as you go through that motion. We're going to go a little deeper now, and I'm going to kind of show you again with the knee position. As you do a quarter squat, your knees tend to not travel too far forward if you're making sure your hips get back enough. But as you descend further into that squat, the tendency is for a couple things to happen. You may start kind of shifting your weight into your toes and the knees come forward, or you may start leaning a lot forward, okay? Now, if I was going to have a preference, I'd say lean. Okay, start with lean. Because to protect the knee from just becoming irritated, not necessarily damaged, but just irritated, we don't want the knee to cross in front of the toe at any point, right? So you can appreciate that, as Jalen just demonstrated, if you start by bending your knees and you squat like that, they're going to go way down. Like try a full squat for me. Just Go ahead and do it. See how far they're kind of creeping forward? That's a lot of stress. Now again, it's not that you're going to blow out your knee, but it's probably going to get mad. Okay? But if we lead with the hips, push back, and see the knees stay nice, just right in line with toes there, and coming back up, that puts much more of the emphasis of the motion into the hips. It takes a lot off the front of the knee and allows you to perform that in an efficient manner that should be pain-free or at least minimal discomfort. But again, the benefit of doing this is it's going to strengthen and stabilize all those key joints that are involved with this syndrome, and it's going to help you to tolerate those key things that tend to flare up better. So doing those partial squats, full depth squats with good mechanics and form is arguably the most important thing of all things that you can do for this. Okay? So it does take some coaching sometimes too, because again, as you can appreciate, there's a lot going on. There's more than we even just talked about now, but those are the key things with the front of the knee. It's like getting the hips back wide and not letting them creep forward, and they shouldn't creep forward if you're making sure you keep your hips back. Okay? For all of our strengthening exercises, like I talked about in our last video, and I'll repeat again, minimum 2 sets of any of these exercises, ideally 3, maybe even a 4th if you're tolerating it okay, where we're getting roughly 8 to 15 repetitions. Start off with that lower end, gradually work your way up. If 15 is pretty easy, it's time to make it harder. Okay? These don't have to be done every day. In fact, when we're talking about true strengthening, every other day, roughly 3 or 4 times a week is more appropriate, but it's also important to watch your symptoms and make sure it's not flaring up. Again, all this goes without being said, but again, if you're experiencing these symptoms, it's good to have it looked at because there may be other things going on. You may need other exercises or interventions first. If it's very aggravated, very inflamed, other interventions to help to calm that tissue inflammation or high levels of pain, or other movement mechanics that are going on that are contributing to your symptoms are important to get examined. So that's why we would want to screen that, thoroughly examine that, and give you the right tools to figure out what you need. Because this is a very common condition, but it's very complex in that there's oftentimes multiple levels of different types of movement patterns that are overstressed in this area, and unless you truly address it, you're not going to completely correct it. And so there's literally a dozen different approaches, if not more, on how you can address pain in the front of the knee. So you need to get your right recipe. I think I posted on here too that there was going to be a discussion about surgery too, because there's, is this something surgery helps with, right? Because that question comes up a lot with most orthopedic issues. And with the classic, and the simple answer with just classic patellofemoral syndrome, where we're having pain in and around the kneecap, absent significant x-ray findings where we have bony lesions, fractures, loose bodies, just basically small pieces of connective tissue or bone that have made their way into the joint that are free floating. Absent those significant high level pathologies, this is not something that surgery tends to fix because it's so much of what is driving symptoms is based off of what you typically do. It's an overuse phenomenon. So you're either running too much or doing too many stairs or work stuff is flaring it up. It's movement mechanics, how you're moving, how that knee is positioning with given activities that are overstressed in those areas. The knee itself is not mobile, or there's contributing factors from the ankle and the hip that are leading to being overstressed. And none of those things are truly addressed with surgery. So again, surgery is good when surgery is necessary, but with this, taking that conservative therapeutic approach first oftentimes is what you need, and especially long term. So that's my spiel about that. So it sounds like we have a question.
Yes.
Okay, cool.
Okay, so this is from Lanny.
Lonnie.
Sorry.
Lonnie. Hi, Lonnie.
All right, so Lonnie says, I have old skiing injuries to both knees, and I live in a split-level house on a hillside with a steep driveway. When my knee hurts, is it better to try to avoid going up and down the stairs, or to use the opportunity to work those muscles more?
That is a great question. So in a nutshell, we have the knee pain already, and we have stairs in the home that we use. And is going up and down the stairs when my knees are painful, is that going to be, in essence, helpful or harmful? Is going through that and going through a painful activity going to be effective, or should I be avoiding it? The typical way that we approach something like this is when you're having pain with that given activity, it's important to attempt to modify it if you can. So doing the stepping in a different way, similar to what we just did with the squats, where your hip and knee position are slightly different, effectively where you're not letting your knee go forward when you go up or down the stairs, to try to put more of the emphasis into your hip. In fact, why don't we're going to grab the step. I'm going to show you what I mean by that. Showing is easier than telling. So imagine this is our step, okay? And Jalen's got knee pain, okay? To offload the knee, if he takes a step up, okay, and this is roughly the same height as the step, if he lets his knee go forward like that, just like with a squat, it's going to hurt more. And the natural pattern that we go upstairs, we get a little bit of that. It's the easy, seamless route when we don't have pain. However, if the knee hurts, we want to offload the knee slightly by not letting it drift forward at all. So I'm going to just use my hand as a block, and he's going to step up, and he can still manage to step up through a slightly different pattern without letting that knee come up by using the hip more. And so doing an exercise like this, where you have a step, or you have maybe your stair, like if you wanted to step on a stair and grab like a broomstick handle and put it right in front of your toe and have it held straight up as kind of a cue to like not let it go that high. Perfect. I love all the helpers around with this, right? So Jalen's going to do it himself. He's going to put it right there. So imagine this is probably up on the next step, straight up and down. He's just going to hold that. He's not going to put a lot of weight into it because, again, we still want to make sure that all your weight's in that leg as you step. But holding it in place, he's just not going to let his knee touch that. And again, that should offload your knee to an extent, right? If you're still having pain with that, it becomes more of a question of how intense is the pain itself? We do know that with specific isolated knee strengthening for patellofemoral syndrome, mild amounts of pain are appropriate. So when we think of our scale of 0, no pain, 10, worst pain imaginable, 1s, 2s, maybe getting up to a 3 out of 10 pain or discomfort that does not linger after the activity and does not aggravate your knee the next day is appropriate. And so if that being said, if you've modified the step and you do it and it seems to be just mild amounts of pain and it doesn't flare up, I'd say it's productive. And so then I would have you doing the stairs regularly as a means of training your knee. Okay.
One more question?
Yeah. If it's above that though, that's when we'd probably want to take a look at it or not perform the stairs. Limit your trips, right? We have another question though.
It's just same from Lonnie.
Okay.
She said, how about stepping sideways up or down the stairs?
Yes. I mean, that's kind of almost the same concept. Again, when we step sideways, we're changing the movement strategy. So it is offloading it. But at the end of the day, that is a mechanism. That is a way to do it. It's probably more efficient doing it that way, going down than up. Going up, we have this good control of the hip and the knee and its positioning, where we ideally can be strengthening it to be advantageous. The problem with the down is we can't modify it this same way, and you're going to put quite a bit of torque into the quad muscle itself going down. And so oftentimes that's what we usually see with this too, is that, okay, we start getting it calmed down, strengthened, going upstairs, it starts becoming under control, but downstairs, still a no-go, right? Having a controlled amount of downstairs walking or training, similar to what we just did now, where you're controlling slowly a descent down, is good as an exercise. But if you're doing it multiple times per day and it's past that threshold we talked about for pain levels, it's probably becoming unproductive. And so a sidestepping mechanism for going up and down, specifically especially down, is probably more appropriate. And if you're not concerned with balance to an extent, retro walking, like literally going down backwards, is honestly probably the way you can offload it the most compared to down. But again, there's just safety concerns with that, but that is a strategy. Okay. Cool. Any other questions? Okay. So just to recap, taping, cool, it's fine. For up to 4 weeks, but you got to exercise still. Bracing, it's usually not very effective. Foot insert for the arch can be helpful again, but we need to be exercising too, helpful up to maybe 4 to 6 weeks. But specifically hip and quadricep or thigh muscle strengthening activities are really the gold standard for this. Combined therapies are more effective than anything in isolation. This is a thing that can be fixable if you address the key things that are underlying your condition. And it gets better. But we want to avoid that re-aggravation that is so common with this. So if you have additional questions with this, definitely post them. If there's more specific needs and things you guys want to dive into further, I'd be happy to put out more content. I've got lots of time and I love doing this stuff. So just leave your questions and we'll get back to you. Thanks.